Well, hello, and welcome to my case study on pediatric musculoskeletal. So, a 12-year-old female arrives in the clinic for a well child check, a pre-sports physical examination. So, the heart rate of the child is 78, respiratory rate is 16, blood pressure is 100/50, temperature is 98.2. Does anything in that strike you as unusual? No, those are all normal vital signs. During the pre-sports physical, the nurse will check the patient's strength, and this patient has a strong um, muscle reaction, and it's equal bilaterally. The deep tendon reflexes are brisk and also equal bilaterally. Range of motion is full, so the patient has no limitations, no injuries causing them not to be able to move their arm or leg in a certain motion. The client describes no pain and specifically no back pain. The lungs are clear to auscultation. The cardiovascular system, the heart rate is regular and the rhythm is regular. No murmur. The peripheral pulses are strong and equal bilaterally. So what is significant though is that the RN notices that the patient has unequal shoulder heights when the child is sitting in the examination room. And also when the patient bends forward, we can check there is a lateral curve of the spine. And we can use a device called a scoliometer, which looks like a little tiny little level that you use if you're going to bring a picture up or hanging tile or something like that. You use a level. A little scoliometer looks just like that, but you place it over the patient's back as they're bending forward, and it'll tell you the degree of curve that the patient has. And this patient has a 25-degree curve, so that is pretty significant. Now, sometimes patients may have unequal leg lengths. So if one leg is longer than the other, it will potentially look like the back is curved, but actually it's just that the upper torso is shifted because the hips are at a different height. But there is no leg length discrepancy. So to do that, you just measure the length of the leg. So this patient is diagnosed with scoliosis by the provider. So it is a lateral curvature of the spine. Now there's a few different types of scoliosis, but the most common is idiopathic, meaning there's nothing else that is causing this disorder. Child could be born with a congenital condition or could have another acquired condition, which would be pushing and causing this curvature. But this child has idiopathic, so there's no other associated disorders with this condition. And there are different hypothesized etiologies, but really the cause is unknown. So how are we going to manage this child's scoliosis? Well, number one, we need to prevent the progression. This child is 12, so she may have more linear growth in store for her. So we need to prevent the progression because as the child grows, the curve could get worse. If the child is at the top of where they're going to reach their adult height, then there's less concern that the scoliosis is going to get worse because there's less chance of growth. We need to make sure that the heart and lungs are not impacted. Because think about it, if the scoliosis is significant, it could be kind of limiting the space or crunching the heart and the lungs and could decrease its function. We also want to make sure that the treatment is based on the child's age and, of course, as I stated earlier, the expected growth. Also, the severity of the curve. If the child just has a 5–10% curve, that is going to be different than if a child comes in with a 40% curve. So this child is a 25% curve. Serial x-rays will be done. So x-rays will be monitoring the child's curve. Bracing usually occurs when the curve is between 25 and 40%. A surgical correction or rod placement is usually done for curves that are more significant or over 45 degrees. So the nurse will have to assess this patient, and her potential for growth is important. So she got her first period at 11 years old, menarche. Menarche was at 11. Her last menstrual period was 2 weeks ago, so she's getting regular periods, and she's now 12. If she hadn't gotten her first menstrual cycle yet, that would mean that she potentially has more growth to go. So it's just one factor that we use to determine potential for growth. She has had secondary sex characteristics that have developed. She has breast development, which is at a Tanner stage 4, and pubic hair, which is at a Tanner stage 3. So she has developed in puberty. The mother reports that the child did have her biggest growth spurt. She estimates between 9 and 11 years old. That she really shot up, and that was 3rd, 4th grade. She got really tall, and now she's kind of leveling off. The parents state there is no family history of scoliosis. And interesting, the mother reached her adult height at age 13. So she said once she hit 8th grade, she was done growing. And it is genetic. So we do look and see what the pubertal development was of the mother. So how are we going to manage this child? Well, we did an x-ray, and it shows a 26-degree curve. So the x-ray will give you an exact curve, and the way that you measure that is when you have the x-ray, you can use your own measuring device to calculate the exact curve. So it's more precise than a scoliometer. So the x-rays show a 26-degree curve. So we do know that we have to put this child in a brace, in a back brace. So number one, pens up, we have to encourage compliance. Because this happens at the teenage years or right before puberty or at puberty, girls are, well, boys can have scoliosis as well, but these adolescents can be very conscious of their body image, so they are not going to want to be different than their peers. So to tell them that they have to wear a brace almost all the time is pretty significant, so we need to really encourage compliance. The brace is worn under clothes, so they can camouflage its appearance. You can encourage baggy clothes, so the brace is not noticeable. Pens up, the brace is worn for 23 hours a day. So it's not something that the child can just not wear to school. They have to wear it 23 hours a day. So that 1 hour, they should choose carefully. They can either take it off when they eat if they're uncomfortable, but again, just 1 hour a day. So they can't take it off 3 hours a day. If they are going to shower that day, they definitely will take the brace off and then shower, and that's usually what we recommend. If they're having difficulty during meals, they can just loosen the brace a little bit to make it more comfortable for them. We do want to encourage the parent and the child to watch their skin, make sure they're not having any skin breakdown, especially if they're wearing the brace right on the skin. Want to make sure that they're putting it on when their body is dry, that it's not where they come out of the shower and they put it right on because it'll get all gunky. They want to dry off and then make sure that the brace is kept clean and watching for any kind of skin breakdown at all. The child can be encouraged to wear a t-shirt under the brace to make it more comfortable and to prevent so much rubbing against the direct skin. And back exercises are recommended. We do tell patients not to sit for prolonged periods of time if possible. So sometimes if they could have a standing desk, or at home if they could stand more if they have to sit in class, that is recommended. So this child returns in 1 year, and now the curve is still progressed. The curve is 45 degrees. The child admits to not wearing the brace as instructed. He found it very difficult, was embarrassed. So the curve has progressed. Listening to the patient's lungs, her lung sounds are slightly diminished. So we are now concerned that there is respiratory compromise because of this curve. Her cardiovascular status is intact. So surgery is scheduled. So this is a rod placement. Preoperatively, we are going to meet with the patient to discuss what this process is going to look like, how they're going to need to do coughing and deep breathing exercises postoperatively, how they need to be positioned postoperatively, which is very important. And then we'll also review the pain scales. Postoperatively, the patient returns from the OR, and as the RN, we are going to do neurovascular checks. So you're checking pedal pulses, capillary refill, sensation, very frequently, and then it progresses as the post-op period lengthens, and vital signs very frequently. Excuse me. When we are going to move the patient, we have to log roll them. So that's a pens up. We can't have them turning their back in different positions. We need to keep that back perfectly straight. So if you see that picture in the top right-hand corner of the screen, it's also in your book. That's an example of how you need to log roll a patient. You have 2 nurses helping you, keeping that perfect alignment with the patient. We're definitely going to avoid any flexion of the back. We will be administering IV antibiotics prophylactically because the surgery is so close there by the spine. We need to make sure that we give antibiotics because we don't want to get an infection in the spinal cord. We're going to be watching carefully for any drainage at the surgical site. The patient most likely will have a Foley catheter still in place. They're not going to be able to move, get up, and go to the commode, or even sit on a bedpan. So we're watching the intake and output very carefully. The patient is usually on bed rest for 2 days. When they do get up, they're transitioned very slowly, and when ambulating, pens up, they have to ambulate very slowly because they are at risk for hypotension. Also, when the patient is in the hospital, most of these surgeries are done the first thing when kids get out of school. They wait until May or June, and then sometimes the units are filled with kids getting these rod placements. They don't want to take time off during the school year. But if they are hospitalized for this surgical procedure during the school year, you'll want to make sure that they have a tutor that can help them with their schoolwork. And that's it. Thank you.